That little thing? 38-foot sailboat around the world. So I asked him if he had his head examined, and my family and I went to Hawaii, Oahu, and they were so gracious to take us to the yacht club for dinner, and we were there with my little grandson, and we come out and we're walking the pier, and he goes up to this $2 million yacht, and he knocks on the side and he says, "This little guy over here wants to see the inside of your boat." Rosalind's pulling me on the side. Yes, he wants to see the inside. So, yes, she knows you. And so, anyway, JJ got to see the boat, and Dr. Steiner got to see the inside. Well, he's going to give us the inside story on a product that I have started using. I am in the habit of ordering almost weekly now, 20 tubes, and we use it a lot. And he's going to tell you how to make it work. Some people have come up to me and said that they've been having some difficulty with it. And with anything, there's a learning curve. But I'll tell you something, and I haven't told this to Dr. Steiner. Last week, I was placing a zirconium oxide implant, and I tried to drill into a site that was 10 weeks old. It was a maxillary premolar. Now, you know, you have to wait 6 months to place an implant in the maxilla, but 10 weeks, and I'm having trouble perforating the cortical plate, so all I did was take a high speed where I wanted it to go, went pop, then did my guide pin, did the guide drill, and then went on. It was fine. This stuff really works. Thank you.
Thank you very much. Well, he does know me a little bit, and he has listened to me a little bit. And one of his requirements for me to speak here was that he said, "Dr. Steiner, we don't want any histology. We don't want any chemical formulas. We just want to know how to use it." So out of respect for Dr. Margolis, we're going to start with histology. My goal here is not to train you how to squirt something in a hole, because that doesn't do you any good. And you're not here because you just want to learn a technique. You're here because you want to understand. There's nobody here who belongs to this organization that's just here to practice. You want to understand. So I will get into a lot of clinical applications, but my first aspect of this presentation is to try to make you understand more about bone than anybody else you talk to. Okay? So we're going to start with normal. This is interproximal bone between a molar and a bicuspid. I'm learning a new technique here. Thick trabeculi, which is beautiful. But what's important here is the soft tissue inside the mineralized bone. All the activity in bone occurs on the interface between the soft tissue and the bone. What this structure is called, it's called a basic multicellular unit. Basic multicellular unit is what's absolutely important for bone to change, adapt, modify. And if you don't have these structures in bone, that bone has no ability to change, adapt, and modify, and allow it to adapt as like your implant changes with loads. So looking a little closer, if I'm in anybody's way, let me know. I am in somebody's way, so I'll move. What you see here is, here's the osteoclasts that are removing bone. But another feature I want you to see is that this tissue is beautifully clear. There's no inflammatory processes, and it's actually fairly simple tissue except when you get to the border. Osteoblasts, laying down bone. And you can see it's sort of a symphony on how it works. The cells in the periphery tell these cells in the border, hey, we need more bone here and less bone here, and that's how the bone adapts. Okay, so biocompatible. You guys are very concerned about what's biocompatible. And so here's a list of biocompatible bone grafts. What makes them biocompatible? They don't cause inflammation. One thing. Second thing is the result of placing these in the area produces normal bone. So a biocompatible bone graft creates no inflammation in the tissue and produces normal bone as a result. We have these three things here. These are the different beta-tricalcium phosphates. Synthograph was early on. It's a very dense, slowly resorbing material. That's one of the reasons why it hasn't been too popular. Cerasorb is a second-generation beta-tricalcium phosphate. It has macropores, which allows it to be resorbed a little quicker. Cerasorb and its competitors have been extensively evaluated, and it's been shown that the second-generation beta-tricalcium phosphates are equally as effective as autografts, allografts, Infuse, or everything. You have no reason to use those products because this is just as effective. Then we get into the third-generation beta-tricalcium phosphate. They are structurally different. They have micropores, but they're all interconnected, and this is the key feature. And so this is our product, Osteoconduct, and it is, we'll go into its structure in a little bit. Okay, autografts. I like autografts because they're obviously biocompatible. So any type of autograft that you're going to use is going to result in normal, healthy bone. These are the bioglasses. The bioglasses are biocompatible. However, they're made of calcium phosphate and silica. The silica provides no use in bone. It's basically a waste product. And these products have been totally outclassed by the beta-tricalcium phosphates, so they're not very popular. Calcium sulfate is not much of a bone graft at all. And in 50% of that material is a waste product. The bone has no use for sulfate, and it washes out pretty readily, so you don't get much use out of calcium sulfate. About the only use of it is if you want to use it as a binder when you're mixing your granules together. These are our products. These are all either pastes or putties, and we're going to go into those a little bit now. Okay, so what are we looking at as far as normal, healthy bone formation? What we want to do is we want to grow bone the same way your skeleton grew bone. And so what we have here is 6 weeks after grafting, we have good mineralization throughout. Key feature, no inflammation, and significant osteoblast-producing bone. This is a blow-up. This is newly mineralized tissue, no inflammation, fat, healthy, happy, actively producing mineralized tissue by these osteoblasts here. So you're going to get normal, healthy bone when you use a biocompatible material. Now, what we have here is you've got to really know a little bit about what's non-biocompatible so you understand why you use the biocompatible materials. And in essence, what you have mainly is you have all these products, all of them have foreign proteins. Another person, another animal, but they're all foreign proteins, and every one of you know if you take a foreign protein and put it in someone's body, you're going to elicit a significant inflammatory response. So all of these bone grafts here create an inflammatory response as a reaction to foreign protein. Allografts, BioOS, Infuse. Infuse is interesting because you think everybody says BMP2. Well, where'd you get the BMP2? You got it from somebody else. You copied somebody's BMP2, produced it in a lab, so BMP2 is an allograft. It's not, everybody's BMP2 is a different. So that's why Infuse creates such inflammatory response. Not only is it an allograft, but it's sitting in a xenograft, which is collagen protein. And that's why you have such tremendous inflammation with this product. Foundation is just bovine collagen. All your resorbable membranes are bovine collagen. Bovine collagen, it's resorbable. Well, why is it resorbable? It's resorbable because it's collagen from an animal, and your immune system's going to attack it and destroy it, and that's how it's resorbed. 2 to 3% of the population is allergic to bovine collagen. So if anybody says, oh, I put a membrane in, it's resorbable, and I got this terrible infection, it really looked horrible. Not infection, it's an allergic reaction to the graft material. Then we have a synthetic. Synthetics can also be non-biocompatible. So now you know the difference. And one thing you have to know is you can't mix the two groups. If you put BioOS with our socket graft putty, you'll get no bone formation. You'll get a terrible result because you've got competing processes. On the one hand, you've got an inflammatory process that produces bone that is not normal, that is actually sclerotic, and we're going to talk a little bit more about that. But these other products that are biocompatible produce bone through a normal heating process, so you can never mix them. It's going to be a failure. Okay. All right. So let's look a little bit about Why is biocompatibility important, and what happens when you use a non-biocompatible material? Allograft. Beautiful result. What everybody wants to see. Dense, mineralized tissue. This is how it gets there. These are the little spicules, little bits of the allograft in the tissue that's at 7 weeks. All this material is dense inflammatory cells. All those cells are cytotoxic T cells. Cytotoxic T cells are the cells that attack grafted organs, so they are involved in organ rejection. Bone is an organ. That's why you would expect them to be there. And you can see we have actually a little mineralization going on. There is no way an osteoblast ever is going to grow bone in this environment. It's a completely different process. And when I talk to oral surgeons, periodontists, and I say, you know, how does this allograft heal? And then I show them this, and they're dumbfounded because they just think they put it in, it turns into bone, it resorbs and goes away, and they have no idea. I have never run into anybody that's actually seen histology from a healing allograft. And that's amazing because it's been around for 25 years. Okay. That case that I showed you earlier, Dr. Margolis will love this histology. Took a core sample of it. These are your particles of allograft that are in that core sample. And it's encased in dense mineralized tissue. And you have none of those basic multicellular units. These allograft particles will never resorb. Resorption of allografts or bio-oss is biologically impossible. I could spend a half an hour explaining why, but you talk to everybody you talk to, they think this resorbs, turns over, and goes away. It's in there forever. This is what people want to see on the radiographs a lot of times. They think, this is great. I got really dense stuff here. This is bio-oss. Well, I took a core sample out of that bio-oss. It's very dense, a lot of mineral, and you can see the chunks of cow bone and the dense mineralization. There is absolutely no vitality there. And I can assure you, you're going to screw your implant in, and it's going to torque down, but it's going to be a screw in wood. It's not going to be integrated. This is what normal bone looks like when you take it out of a core sample. There's always hemorrhaging, there's always bleeding, of course, because it's vital tissue. This is not vital. Well, I'm not going to say it's not vital. There are minute capillaries that do course through it. There are some cells that are there, but they never turn over. They just stay that way. And so this is not dead. It's just very low vitality. Here's that core sample of that bio-oss. You see here's the bio-oss granules. This is a demineralized section. The mineral has all been removed, and so what you have is just the proteins left from the cow that was grafted when you prepare the histology. So this is all collagen from the cow, and you can see that every little bit of these are encased in dense mineral. I don't even know if I can see any blood vessels really in this, but basically there are no basic multicellular units. This bone will never change and never turn over. This is 10 years after grafting. Okay, who cares? It's hard. I like drilling my implant into it. But let's talk about a complication that it comes with creating sclerotic bone. That's the term given to bone that has no ability to change or adapt. No basic multicellular units. You've got bone that's fixed in time. And so let's see what this sclerotic bone does when it comes to our practice. This is a joint, obviously, and you can see there's been an injury here, and you're starting to get a little increase in density. You continue to have an injury, and it produces to move over to this. This is sclerotic bone. If you've ever had a joint removed or anybody else removed, what the orthopedic surgeon is doing, he's cutting this sclerotic bone out. Because once it becomes like this, it can never improve, it can never change because it's sclerotic. And then if you keep using this, it begins to break down and ultimately collapses. Why? Well, what happens is that anytime bone receives any trauma that's short of a fracture, like you step off a curb, if I would jump down on that floor, and you get a jolt to your skeleton, well, you're sore for a couple days later. But what's happened to your skeleton is that you've had microfractures throughout your skeleton that have absorbed that impact. And you're sore for a few days, But it gets better, and all those microfractures go away because you've got normal bone that can go to those microfractures, heal them, and remove them, and you're totally normal again. However, in sclerotic bone, allografts, bioloss, etc., these microfractures that build up can't heal themselves. And they break down and they collapse. So that's what you saw in that joint. Bioss, everything's hunky-dory for 3 or 4 years, and then all of a sudden, boom, it breaks down. This was the first slide. The next radiograph, the thing fell out and it was gone. So what's happening here is the sclerotic bone that was formed around this implant suffered an increasing accumulation of microfractures, and it got to the point where it collapsed and the implant falls out. Beautiful, right? Can't do it any better than that. This is an allograft. It goes along perfectly fine, 3 or 4 years. The patient comes in and says, a little tender, and this is what you have. Microfractures built up to the point where they collapse, and you lose the implant. So you got a choice. You can grow bone this way through an inflammatory process that produces sclerotic bone, which is pathologic, or you can use biocompatible materials that produce normal bone. Statistically, I'm not much into, I don't really care about implants, implant failure and all that, but professors are, and I was talking to one, and he says they've studied the reason for implant failure, the percentages, you know, there's inflammation, there's occlusion, there's cement, there's all these different reasons, but then they have this group X. Group X is that group of implant failures that they do not have a diagnosis for, so they just put them in here because they don't know why it happened. And he told me after his review, 99% of those group X failures were grafted with either allograft or bioloss. And so this is my theory about why that happens. But if it turns out to be true, then by using biocompatible materials, you'll eliminate 30% of your implant failures. Isn't that fun? Synthetics, Mike, I'm almost done here. Synthetics are also not biocompatible. Every one of you here have heard of Bioplant. Well, an interesting feature that nobody knows about, Bioplant, Bioos, all this stuff, the FDA will not permit a dentist to put Bioplant or Bioos in a site, let it heal, and then put an implant in later. Can't do it. FDA does not approve it. So when this patient walked in with Bioplant, I said, you got 2 choices. You can go to somebody else who'll be very happy to put your implant in for you, or you can have me cut it out because I will not put an implant in there. And so she says, take it out. I laid a flap, a conservative flap, because I just thought I was going to dig a little bit out of the socket, right? You can see that the granules of Bioplant had migrated all the way through to the buccal plate. This is what I wound up with as far as having to remove the buccal plate. This is what I left with. I basically had to remove the bone from the lamina dura to the lamina dura to get out all the granules that had migrated through this tissue. Here's the histology just for Mike. Here's Bioplant, I thought was biocompatible because dentures are made out of methyl methacrylate. That's what these beads are. They're plastic beads. And so dentures don't cause any irritation. There are places that you actually inject methyl methacrylate in the body and they don't cause inflammation. So I'm just assuming I got a biocompatible material here, no big deal. But what it turns out is that these plastic beads are covered by a material. They have a coating, and you can see the coating here, 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 and here. This is 3 years after grafting, okay? What happens is that coating migrates into the tissue and is basically clogging up all the cells in the area. Histocytes are coming in and they're trying to scavenge this stuff to try to keep it inside the area without having it to spread. And what you see here is all these histocytes. Here's a giant multinucleated giant cell. And all these histocytes are just clogged with this material, and they're actually laying fibrin bands down to try to compartmentalize this to preventing it from spreading. Okay, let me back up. Now, the interesting thing with this that I found was that I've done a lot of surgery, and so when I was doing this, I make my incisions, my vertical incision and crustal incisions to get to the site, and it bled profusely. I don't remember a patient bleed like this. When you look at the tissue, it didn't look particularly unusual, but when I made an incision, it bled. We had to pack the mouth with gauze because the evacuator couldn't keep up with it. And then when I got to the very end and I'd finally removed all the stuff, bleeding stopped. And I was amazed how quickly the body can respond to the removal of something that's that inflammatory. Okay. All right. Okay, so now we're going to get into technology, and now we're going to get into clinical usages. But what I want to talk to you is about how can technology help your practice. Okay, so when you put an immediate implant in, and you graft around that immediate implant, if you're using allografts, BioOs, BMP2, xenografts, anything, that in the area that you put the graft in, you will not get integration to your implant. You'll fill the defect, but you will not get any integration. And that's why you got to be somewhat conservative, because the only thing that's going to hold that implant in is the native bone that you put it in. The graft site provides no support. Well, that's what this study proved. And so, but what we want to do is we want integration at that graft site. We want to get bone wherever we put our graft material. And so how can we study it, and how can we prove that we're getting it? This is a site, very large defect, very poor healing, no place to put an implant. So we're just going to graft it. We're using socket graft putty and our osteoconduct beta-tricalcium phosphate granules, no membrane. But what we're going to do is we're going to drop an implant into it. And you can see that this is all graft material. The implant is not touching native bone in any place. This is 3 months later. We've regenerated the buccal wall, and the implant is integrated. There it's in place. I'm putting the healing abutment on, and it's in function today. We have a number of other cases just like it, but what we've been able to prove by this technique is that you do get integration in the area of our bone grafts. What's that do for you? It allows you to treat a lot more severe cases that we're going to go over, and you don't have to be limited to small defects. Okay, our products, I'm proud to say, are the only bone graft product in the world that is osteogenic. Osteogenic means that it actually stimulates bone growth faster and more dense than you'd find normally. And there's no other bone graft company in the world that can use the word osteogenic, because it has to be approved by the FDA before you can use it in your advertising. Here's our material. This is socket graft putty in a socket. The orange is our carrier, a calcium phosphate biocement. These vacuoles is SL factor. That's our osteogenic compound. And you can see that we have osteoblasts crawling around through it, and where they run into a vacuole, they absorb the active ingredient. What it comes down to is that you're seeing cells grow through something that just came out of a syringe, but when this material goes into the body, it hydrates from the surrounding fluids, and it becomes a tissue culture. So it's just like growing cells in a laboratory, but you're growing cells in the patient's mouth. 6 weeks, you've already seen this. This is the mineralization we get with no inflammation. This is 9 weeks, beautiful trabeculi forming that are all normal. No inflammation whatsoever. Very intense blood supply here, because this is very active growing. This is about what normal bone looks like. When you're going to have normal bone formation, this is where you get, this is where it stops. However, in our graft material at 14 weeks, you can see that we have about 80% mineralization. Leave it six months, and it basically is all mineralization with the except of vascular supply and basic multicellular unit. These are the histology slides that we used to prove to the FDA that our material stimulates bone growth faster and more completely than normal. And that's why we can use the term osteogenic. Okay. Another feature when it comes to bone grafting using biocompatible materials is that bone graft infections are a problem. When you do an autograft, you collect the bone, you grind it up, you put it in the sinus, 50% of those areas get infected. Very good studies done to show that. And 50% get infected and result in a lower amount of bone formation as a result of it. 5% of all autografts in the sinus have to be removed because the infection can't be controlled. And what causes infections in your bone grafts? What causes the infection in the bone graft is that you're providing a niche for the bacteria to live. All dental infections that I know of, caries, endo type of lesions, they all exist because the bacteria found a place where they can avoid the immune system and antibiotics. And so that's the same way with the bone graft. If you got bone graft with a bunch of holes in it, like an allograft, a xenograft, some synthetics, if there's large pores and you get bacteria in there, well, then they can grow and multiply in an environment that is isolated from your immune system and isolated from antibiotics. So if you don't provide a niche for the bacteria, you're not going to get a bone graft infection. And that's what we've done. This is our osteoconduct beta-tricalcium phosphate granule. And this is after 5 weeks. It's in the sort of coronal aspect of the socket, so bone hasn't gotten to it yet. And you see no inflammation over here, but you see our granule, and you see this layer of cells. Well, the granule is microporous with interconnected pores. So actually, this is demineralized. So what you're seeing here is what's actually inside the granule, which is intercellular fluid. Intercellular fluid does have some degree of antibacterial properties, but more importantly, there are no holes big enough for the bacteria to get into and colonize. And so the bacteria can't get in, and here are these cells. These are called macrophages. You all know that macrophages are the first line of defense in killing bacteria. And they also do one other thing. They also are responsible for identifying a foreign object and presenting that foreign object to the acquired immune system so it knows how to attack what's going on. So what it's doing here is simply identifying this as foreign, but it's not calling in the immune system because there's no inflammatory response. But with this lining of macrophages, bacteria on the surface have no chance. This is a little bit later. This is 3 months. Here's our granule. All those macrophages that you saw lining up on that granule, they actually coalesce and they become osteoclasts. And then osteoclasts have the ability to resorb ceramic products, and that's what you see here, without any inflammation. I skipped a slide. Okay. A little comparison. So we talked about how the second generation beta-tricalcium phosphates are equal to all the other graft materials out there as far as bone production. This is a very well done study, and what they did is they looked at no graft, autograft, BMP2, and third generation beta-tricalcium phosphate. Third generation beta-tricalcium phosphate outperformed all the other grafts. So just the granules themselves of that generation outperform every other bone graft on the market today. Okay, allograft. Nice actinomycetes infection because you provided an area in between these particles and in its pores for the bacteria to colonize and grow. And in this socket that this came out of, the tissue didn't look particularly inflamed and infected, but when you took it under the microscope, you see these areas of colonization, and there was absolutely no bone formation in the socket, and there never would have been. So you would have simply said, oh, the bone didn't form. That's because it was infected. This is a synthetic. These are macropores, which is the synthetics do the same thing. If you provide area for the bacteria to grow in, it'll grow. Okay. How does this technology help your practice? If you can put an immediate implant in and you only need a little bit of bone to stabilize it, and you pack the graft material around it, you're going to have just as good a result as if you were putting it in native bone because you're going to get integration throughout the whole implant. Sinus augmentation. Many people graft the sinus. They wait 3 to 6 months, put the implants in. The reason they do that is because that graft material is not going to integrate to the implant if you put it in immediately. That's why you have to wait for it to turn into bone. With this technology, you never wait. You put your graft in, you put your implant in, because you know that portion of the implant that's sticking in the graft material will integrate to your implant. Antibacterial properties allows you to graft anything. You talk to a lot of oral surgeons, and they'll say, oh, this is a big infection. We've got to take the tooth out before we graft it because the graft will get infected. Well, if they use the proper technology, they never have to do that anymore. And it also prevents all the complications associated with bone graft infections. I basically use bone grafts on everybody that walks in my door, and I simply never have had a sinus graft infection, and maybe have had one post-operative infection where we've used our graft materials in a socket. Okay, we get to teeth now. Okay, so what I want to say is I really don't like lecturing. I'd rather have a discussion. And so if any of you have a question and you want a specific thing answered as we're on a specific slide, raise your hand, or you can ask that lady in the back with the big voice to do it for you. She was here last lecture and she did very well. So basically what we're going to be looking at is just simple extractions in the aesthetic zone that are a complete socket, simple grafting. This tooth's failing. We took the crown off the tooth, sectioned it buccal and lingual. Since I've been using this technique, I have never damaged the buccal wall, because what you do is you go in, and now what you do is you, mesial and distal, you collapse the root into the socket. The traditional way of taking out a tooth is you grab it and you wiggle it, and what you're doing is expanding the socket till a point gets to the point where that oddly shaped root will come out, right? Well, the socket may look okay when you look at it, but it is a disaster as far as what damage has been done to it. Tremendous amount of inflammation results and resorption, plus postoperative pain. And so we're going to collapse the root in, and we're just going to pop the root out, which is what usually happens with this technique. We're going to fill it up with graft material. This is our socket graft putty. Syringes you mix it together, you just squirt it in the socket. I think I need to go in this direction. Okay. We don't want to lay flaps. We don't want to expose the bone. If you lay a flap or tuck a membrane underneath the gingiva, you will create an additional 1 millimeter of recession. And so we just want to put the graft in, and we cover it up with this material. It's called a socket seal, closed cell foam. And then I bond it with an oral adhesive. This is an oral adhesive. We now have it at the FDA. So we bond this in. And now after bonding it, you've got a hermetic seal. No bacteria, no fluids, no nothing's going to get into your graft material. And then we put in a couple retention sutures, and then I rebond it. And that's how we treat the standard routine extraction when there's all walls present. Now, our graft material, you saw that was a putty, okay? It has no ability to resist pressure. Many people that have been doing bone grafts, they have to pack it. Got to pack it in. They just don't feel comfortable. Well, you can pack all day. Our stuff's not going anywhere. The harder the material is, simply the longer it's going to take to resorb. And so why have a hard material if you don't need anything to maintain volume? So get a soft material. Let the cells grow into it. Get a soft material like our putty. Nothing in our putty isn't already in the patient, and everything in our putty is converted into the tissue that it forms. And it's just, it's basically the cell's diet, in essence. And so here we go. We got a nice fistula out here. And we also have a little bit of a missing wall. That's a bit of a problem. And so, but I really, this patient takes care of themselves. They're an older patient, but they're concerned about aesthetics, and I really like to try to maintain the aesthetics as best I can. Here's the tooth. Here's the tooth before. And what we did is we grafted. We put the implant in the same day. So what we did, we had a buccal wall that's missing. Whenever we have any part of the socket missing, I treat it, whether there's an implant there or not, I treat it all the same way as far as the grafting. A buccal wall missing, I mix the putty with the granules. Think about it this way. Why do we use granules? And this is the only reason you ever use any granules, because no granules do anything other than take up space. So what you have is when you're making your mix of your granules, you have these granules, and all the granules need to be on top of each other and connecting each other. Because if you have something like that and you press on it, it will resist being deformed because they're all together and they're touching. You can't compress that material. But if you make your mixture up and you have 2 fruit granules, so they're sort of spread around, well, then that putty can't resist the pressure and you can squash it. So your mixture needs to be a high percentage of granules, and the only purpose of the putty is to fit in between the granules. The putty does the stimulating, the putty does the ossification, but the granules are holding space for you. And that's why you use the granules. So here we are. This is the day. We got the implant in place. We got our graft with our granules in place. There's our defect and our missing wall. So what I do is, whenever you put in an immediate implant, you always have a lot of irregularities. There's very few sockets that are perfectly clean. Oftentimes the implant might be up against the lingual wall or something, and there's a lot of little nooks and crannies in the area. So what I like to do is our mixture is that we use half the syringe of socket graft putty, and we mix that with 0.5 cc's of granules. Mix it up in a bowl. We still have your half a syringe of socket graft putty. So what I do is then I just inject the socket graft putty into the socket, and I know for sure the graft material is contacting everything. So the graft material is flowed around, all the little nooks and crannies, and then I pack in my granules and my putty. So I follow it up with packing in the granules mixed with the putty afterwards. Okay? When you put it in, you don't need to condense it. Just get it in and smooth it off. Put the seal in, suture it. This was a little older before I was doing adhesives, and so we just put a couple retentive sutures in without adhesive in this case, but that's before we started studying it. Now, we always use an adhesive. What's on the market now is periacryl, which is very similar to our material, and you just bond it in. Okay, you're going to bring the patient back and remove that seal, and when you remove the seal, you're going to have this depression where our seal was put setting. That's what you want, and you want it because what you're going to do is, for this patient's temporary, you're going to make a Essex retainer with a Pontic in it for them to walk out the door the day of surgery so they have a tooth. But it's not going to contact anything. It's not going to contact the socket seal or anything. There's going to be a space. But when they come back to take the seal out, you simply add acrylic to this and put it back in, and you've got an ovate Pontic that fits that depression perfectly that will help maintain your gingival margin. Like that. Now, also, when I go to put healing abutments on, I never remove any gingiva. Gingiva is precious. There's always something you can do with it. So when I put my healing abutments on, I just make a small incision because I did have a small amount of resorption out here, but I made a small incision, and when I put this thing in, it just pushed that buccal gingiva out to help me correct my aesthetics. Okay? And so we have before and after. And that's the result, complete integration of our implant. Okay. Yeah, this looks like it's failing. I'm going to do the collapse of the root in the socket. Here's a case where we're going to put a temporary on. And so whenever I've got an implant in and the walls are all present, and I don't have a big gap between the implant and the bony wall, let's say it's 1.5 millimeters or less, I don't use any granules. It's totally fine just to go in with the socket graft putty. So I put my healing abutment on, or my temporary abutment on, and I just fill everything in the socket until it exudes out all over the place. And then what I do is I just wipe off the socket graft putty in this region, and I put in the temporary. A couple things that I like to do with this is that make sure that you reduce the mesial and distal of the tooth so there's no contact here, so that any forces on those adjacent teeth won't be transmitted to your implant, and also reduce the occlusal edge. And then I put in an ovate Pontic, Essex retainer over the top of it that's been relieved about 0.5 millimeter. So this thing is perfectly protected. Nothing's going to touch that implant. I tell them you wear it a month. In a month, you'll be adequately integrated. You won't have to wear the Essex anymore. But the biggest reason for immediate implant failure when you're putting in a temporary is because you have some type of contact to it. A case in point that I want to bring up. You always learn by your mistakes. At least I like to make mistakes so I can learn, right? One time what happened is that we made the Essex retainer like I showed you in the previous case, and it didn't contact the socket seal. It brought the patient back. We converted that into an ovate pontic. The patient walked out the door. I didn't find out later and said, the patient says, that tooth always touched my implant. So here what we did was we put an Essex retainer right on top of the implant, and it failed to integrate. So make sure there's a little bit of space between your ovate pontic and that implant. Make sure they're not in contact. Okay? Is that clear? Okay. All right. All walls are present. Implant with the temporary abutment, grafted. I show this slide because here you can see the graft material in place. It pretty much covers everything to the point of the edge of this temporary abutment. And this is what it looks like after it heals. You have bone regeneration right to the edge of the implant. Okay. All right, now we're going to talk about extractions, but extraction sites that have a missing wall. Particularly this case is it's missing between the implant surface or the grafted surface and the tooth adjacent to it. What we have is a protocol that covers all of these issues. All these things are in a protocol. Every time somebody orders, at least in the beginning, we send the protocol out, and if you have a patient with a problem, you go down the protocol and says, oh, that's loss of a buccal wall, this is what I do. Tells you exactly what to do and what materials to use. So don't worry about writing this down. I'm going to get it all to you. All you have to do is ask for it. Okay, let's take a look. Well, this is a pretty ugly situation. We've got loss of bone here, residual endodontic material. I don't think that's necessarily biocompatible. And so I tried to get the endodontic material out through the socket. I couldn't do it, so I had to open the tissue up to get the endodontic material out. And so I've got a nice extraction socket with a fenestration. So how do we handle fenestrations at the apex of an extraction socket? Anytime there's any defect in the socket, we mix the putty with the granules. The granules hold volume for us, okay? And so what we have here is we have the graft material that's the socket graft putty mixed with the osteoconduct granules. But we're going to put an implant in there anyway. So what you see here is that this is the amount of bone that we have, native bone contacting the implant at this point in time. So it's in this much of native bone, and you can see that this is all graft material here. Okay? And you can see that the fineness of this radiograph shows that the socket graft putty mixed with our perio granules, which is our smaller size granules. Whenever you're grafting and the graft material is going to come in contact with an implant, I would recommend that you use the small granules. The standard size granules are up to 1 millimeter, and it's like boulders on the surface of the implant, and I think it can interfere with healing to some degree. So always, whenever you're going to have graft material with the granules, always use the small size granules. Okay, this is what it looks like. We're going to put the healing abutment on. That's at 7 weeks. Sometimes I sort of cheat to sort of look at, obviously I need to open that up to look for a healing abutment, right? But basically, this is what the implant looks like, and you can see that we have some of the osteoconduct beta-tricalcium granules left over. The granules resorb within 3 to 6 months. They're designed to resorb within 3 to 6 months because you're going to go back in with your implant around 3 months, and so if the granules are still there, they're still maintaining volume, but after you put your implant in, you want those granules out of the way. You don't want them around for a year or two. And so they're designed to sort of resorb according to the time frame in which you're going to be putting in your implant. Okay? And so this is 7 weeks after grafting. You can see that this bone is looking quite different in the area of the graft. This is after cementation and function. And you can see that we took that really nasty socket and created the bone that almost looks like it was perfect before we started. Now, it says 7 weeks. I wouldn't have scheduled him in 7 weeks. I didn't know it was 7 weeks until I started putting this together. I said, how did he get in 7 weeks? I don't recommend that type of case being treated at 7 weeks. Give them a little more time. The more bone loss, the more damage to the socket, give it a little more time. That case probably would be best treated in 3 months. Then you'll have plenty of time for integration. 7 weeks is too early. Beginning and end. Okay. Clinically, this is what it looks like. We lost a little papilla here, but overall it looks pretty good. Okay. I don't like lectures where everything's perfect because I don't believe them. And so we're going to go through some problems. This is a tooth, obviously it fractured off. I had done this implant before with a sinus augmentation, and this patient wasn't bad enough to let this get fractured off and have a periapical lesion in my bone graft in the sinus, but you have to take them as they come. So what we need to do is extract that tooth and put in an implant, grafted it. It was a good candidate for an immediate implant. There was good bone up here, and there was a good socket because it was a skinny root, and healing abutment. Look at this. How did that happen? Okay. Another case. Tooth, we're going to do an immediate implant. Yes. Yes, that's exactly what I'm going to do, but this recently happened, and I thought, oh, this is a good one to show. I haven't treated it yet, but I'm going to go in. Now, the benefit we have is that the defect is not a chronic infection. I don't know why that bone didn't grow there, but in that period of time, you're not going to get a chronic infection, I don't think. So you're going to be able to treat the root, to detoxify it very quickly. There's not going to be calculus there. Very high probability of regenerating that lesion by your standard method of treating those type of pockets. Yeah. So I'm going to go in and treat it. So this is another immediate implant case. We did have quite a bit of a defect here and this is all graft material. And look what it comes back to. Now both of these implants were integrated, probably unfortunately, but now I got another big defect here that I've got to deal with. Okay, so I'm saying to myself, this doesn't happen very frequently. I don't understand what's going on. I went back and reviewed the charts. Both of these patients were smokers. Taught me a very good lesson. I'm no longer going to do immediate implants in smokers because this is what's likely to happen. In a smoker, I'm going to take out the tooth, graft it, put the implant in as a delayed implant to avoid these type of problems. Dr. Margolis relayed to my wife he had a failure recently. Person had a drinking problem, is that correct? Okay, and so he asked, can that have something to do with it? I think absolutely correct. Somebody that's putting that much toxin into their body, their metabolism is not good. Don't expect normal healing. However, you know, with the other standard diseases, diabetes is one. I don't see the difference between the regenerative capability of a diabetic or a normal person. I treat them the same. I don't seem to have problems. So it's mainly smoking, excessive drinking. Okay. Let's say we have a case where we just have little bone support, like that. Severe lesion, fistula, bone loss on this root. But this is a lady that's very concerned about aesthetics. She wants an aesthetic result. Well, with all this damage, how am I going to really treat this effectively? I'd have to lay a flap. I'd have to do a ridge augmentation. And who knows what kind of collapse I'm going to get when I do that. So I really want to treat this and try to maintain the gingival aesthetics that she has here. And so, because the only place I can get retention is at the coronal aspect, I had to put in a 5mm implant because that's the only thing that would contact. And in this region here, I just debrided it, grafted it with socket graft putty. We actually put a temporary on this tooth, did the Essex retainer routine that we talked about, and this is day of cementation, and this is from here to here. We regenerated the bone along this tooth and all the bone around this implant, and basically that's how you can use technology. Yes? Totally through the socket. Yeah. I really don't want to lay a flap unless I have to. Okay. Pre and post, I think we were successful. Okay. Okay, now we're over to molars. How do you treat them with just a simple extraction? Pretty straightforward. All the walls are present. There's no sinus perforation. Extract the tooth, fill it with socket graft putty, cover it with socket seal, bond it, put a retention suture in. I actually like a little crisscross now. It holds it in a little better. The whole reason for doing this is the adhesive is going to isolate the graft site and the wound from the oral cavity, but it's going to break down in about 4 or 5 days usually. So I put the retentive suture in just to keep it in place and make sure the patient doesn't either inhale it or swallow it or something. That's the purpose of the suture. This is 10 weeks after grafting, and we can see that we maintain the ridge. We have a nice mineralization. We do have somewhat of a lower sinus here. And this is what you're going to see in 10 weeks. You're going to see more dense mineralization here than you are at the crest, because the mineralization will proceed in a manner that the further away from where the osteoblasts live is going to be slower to mineralize. The farther they've got to crawl to get to the area of mineralization, the longer it's going to take. And so that's why this is not quite as dense as this, but it's full of highly proliferated, regenerating osteoblasts, and that's what you want to put your implant in. Old technology talked about mineral density. New technology talks about vitality. What integrates to your implant? Osteoblasts. Osteoblasts grow onto the surface of the implant, mineralize it, and hook that mineral to the bone. You want the more osteoblasts you can get, and the more mineral you have, like in sclerotic bone, the less vitality you have. You need a good balance, some mineral, but most important, you want as many osteoblasts as you can get. Okay, so here's a core sample, nice healthy bone. Here's the implant. So we put the implant in, and you know, I'm getting up here, and I says, I want a little more bone here. So with our material, our sinus graft, it comes in a syringe also, and when you're using that through the osteotomy to do a little sinus bump, basically you don't need to create a big hole into the sinus. You don't need to manipulate the membrane. All you need to do is get a pinprick to expose the membrane, because you got a syringe with hydraulic pressure, and you put the pressure into the osteotomy, and it's going to flow through that little pinprick and lift your membrane. And that's why it's easy to do just on a regular basis for simple things like this. Okay. Again, we don't want to show perfect cases. Yes?
How much do you inject? Because the sinus phase is much easier flowable than your socket phase.
Mm-hmm.
So you don't want to inject the entire tube.
You want to inject as much as you think you need. What I like to do is I'll get the syringe in there, and after a while you do a number of them. You actually feel, like you can take a little bit on your table and you can express a little bit. So you know what resistance you get. You put it up there, and if you're injecting it and you got more resistance, you know the membrane's intact and you're lifting it. And so, but what I like to do is, depending on how big a graft I'm doing, I will inject some, and then I'll take a radiograph to see where it's at, make sure it's contained underneath the membrane. And if I got enough lift, then I stop. If I don't have enough lift, I just inject more. And we'll go a little more about that when it gets to sinus augmentation. This was a guy that came in, young guy. He had some developmental problems, but he had a canine that was impacted. It was pulled into position. It turned out that the root tip was actually into the floor of the nasal cavity, and it had root resorption and ankylosis. And so I was thinking about an immediate implant when I first started, but after having to sort of grind out this root and actually have to grind the root out the apex, it was really too big to get an implant in. And plus, with all these complications, exposure into the sinus, I just thought the best thing to do here is just to graft it, lift back up, we can put the implant in later. And so what I did here was in this case, I mixed up my graft material, and I used socket graft putty plus the standard size granules, because there's no implant going to be placed. And I packed some in. I took a radiograph, and you can see my graft materials right here. I says, okay, I got to put a little more graft material in. And so now I have some graft material actually expressing out into the floor of the sinus. That's not a problem. It'll just wash away if it's not used, and the sinus will see, the floor of the nose will seal off. However, this is how he came back 2 weeks later. This happens. Half of the graft material has washed out. But what you see here is that this is graft material. But you see that the walls of the socket are coated. The material is a biocement. It will not wash off the wall. You can get the graft material out of the socket sometimes, suck in on it, who knows, whatever reasons cause it to come out. But the material that's bonded to the socket wall will stay. And that's why the vast majority of these cases, when I see the socket covered with the material, I just leave it. And I just say, okay, well, before we could have brought you back in 2 months to put your implant in, but because we lost some of the graft material, I'm going to wait 3 months, and you're going to find a very well-healed socket. Very nice bone mineralization. Because you got to think that when you have the coating on the socket wall, you have SL factor exposed to the osteoblast, but just as importantly, the bone is covered, and you're not going to have any complications from exposed bone. So the bone will go from extraction to regeneration as opposed to extraction and resorption if you don't graft. Okay? So, what I did in this case, because it was in the anterior, because it was up front, because it really wasn't the greatest compliant patient, I ended up grafting this one. I just simply removed the graft material that was along the wall, I regrafted it, put him on antibiotics, and sent him on his way. But usually, when I see something like that, I don't regraft. Okay. What do you do when you take out a tooth and you got a minor perforation at the apex? Squirt your socket graft putty in there, express a little bit into the sinus. You can take a radiograph and ignore it. The socket graft putty that goes into the sinus is just going to be washed away, and it's going to go out the sinus, and it's going to heal just fine. However, what happens when you got a significant perforation? We basically got root tips that look like they're right into the floor of the sinus. Sure enough, take it out, all 3 roots had sinus perforations. So how are we going to treat it? Well, I'm going to graft it, and I'm going to cover it with my socket seal. I'm going to bond it, and I'm going to suture it just like we always do. But you know what? If a person sneezes, they're going to blow that out of there. If suck on malt hard, anything that builds up significant difference in pressure between the sinus and the mouth is going to disturb that. So what can we do to prevent this being displaced? In this case, you guys have got probably a better technique because I'm a periodontist. I don't know anything about materials, so I just laid a little cellophane over, took an impression, and we made an Essex. The Essex, here's our socket seal, here's our Essex retainer sitting right on top of our socket seal. So then I told the patient, you wear this constantly for the next 2 weeks until I see you, other than to clean your teeth. So now what we have, this person could go out and exercise, he could sneeze, but with that Essex retainer very stable, you're not going to blow the graft material out and not going to end up with an oral antral fistula. Very simple, quick thing to do in the office if you run into that problem. This is what it looked like a month later, and we're getting some bone formation a month later, and this will fill in time. Obviously, if you're going to need to do an implant, you're going to have to do a sinus augmentation, but at least we prevented a fistula. Another nice case, loss of the buccal wall. Also, sinus perforation with an infected sinus. You can see that this is all infected material up into the sinus. Guarantee you're going to have a nice sinus perforation when you go in there. This is the hole into the sinus, and we lost the buccal wall. So what I do when I'm treating sinus perforations that are significant at all, I mix my socket graft putty with my granules, and I just pack it up there. This is the floor of the sinus, and it's being expressed out up into the sinus. As you recall, these bone grafts aren't going to get infected. You don't have to worry about the granules rolling around and collecting bacteria. And believe it or not, the sinus does have the ability to remove these granules from the sinus. So this is what it looked like 2 weeks later. We have some loss of the buccal wall here, but we have nice healing and sort of a fibrin tissue over our bone graft. This is when we're taking out our socket seal. You can see we have some residual granules up here after 8 weeks, but we have nice elevation of the membrane, and so this little graft material that I stuffed up there has actually allowed us to get some bone formation, and I could tell that by when I went in with my pilot drill, this is mineralized tissue. Place the implant, and here's a more severe case. You're going to take that tooth out, you're going to get a very big hole. I'm going to treat it the same way, except That's a slight overfill, don't you think? I took a look at that and I thought, oh, wow. Generous. Yeah. Where I work, I don't pay for the bone grafts, right? Okay, so this is not going to be a problem, believe it or not. Hopefully, we can prevent this an oral enteral fistula from forming, and this material will, who knows, may turn into some bone, but the majority of it will probably just be washed out. At this point in time, this material is probably hard, but it's going to break down in time, and will probably just be washed out of the sinus. But our goal is no more than to close this wound. Okay. That was half a cc, or half of the syringe of socket graft putty with 0.5 cc granules. That will fill the biggest molar that you can find, biggest blown out molar you can find. And so, and I didn't even use all of it for that. Obviously, I thought I was just packing a little bit, right? Okay. Loss of the buccal wall. You're going to run into this constantly. This is an older gentleman. I'm a periodontist. He says, "Doc, leave me alone. I'm old. I don't care." So I says, "Okay, we'll just replane it." But this tooth he wanted replaced, and when we took the tooth out, there was no buccal wall. So we put in the implant. We grafted the buccal wall. Again, socket graft putty with perio granules. And because we had a low sinus here, we did a little sinus bump, penetrating the floor of the sinus, injecting some sinus graft up. One thing you shouldn't be tempted to do is that if you're going to inject anything into the sinus, you've got to use our sinus graft because, as Dr. Margolis pointed out, it flows freely. You don't want to do that with putty because then you're going to have sausage up there because it won't flow, and it'll just be a big strand. So only inject the sinus graft material into the sinus. Yep. Mm-hmm.
I drew blood, and then I planned it out, took the membrane up there because there was nothing to prevent it from going all over the sinus except the TRF membrane. And then I was able to place your product in the feet and place it up there, and then took a zirconium oxide implant and screwed it up, and it has sealed very nicely.
Perfect. That's great. There's a reason I don't use a lot of membranes. We don't make them. And so we're going to talk a little bit about membranes in a minute, but that's perfect. That is a good solution to this. A lot of people that don't have the ability to use that autograft for a membrane would use a collagen, a resorbable collagen with their allografts, but you can't use resorbable collagen with this. Okay? So we've got graft material everywhere here. And this is 15 weeks later. He's coming back in. We're going to put the healing abutment. We got some nice bone formation up here. The bone is looking pretty mature in this region. And, sometimes when I'm putting my healing abutments, I really have to check that implant, make sure it's good, right? So I wanted to see what's happening with the buccal wall. So this is the bone that we regenerated on the buccal wall. And you can tell because these are some of our osteocondyct granules. As I say, 3 to 6 months to resorb. There's always going to be a couple laying around, so this is the wall that we regenerated. Okay, let's take a look at another missing wall. Missing wall here. Grafted it. I just, whenever you have a problem when you're doing an extraction, you really don't have the time or the patient's not ready for a full-on ridge augmentation. So I only just do a socket graft, but I try to do it in a way that maybe we can prevent a ridge augmentation down the road. And so this is grafted with socket graft putty with the standard granules. And this void right here is the gingiva that was there. That's why you see the void. And then the socket seals on top of it. Ridge after 11 weeks. And you can see this is the new bone that's been regenerated by the graft material. And you can see that's different from the old bone. Take a little closer look. There's the implant in place that day. That's what it looks like when we're going to put our healing abutment on. And that's what this regenerated wall looks like at the time of our healing abutment placement. So Nothing's a guarantee, nothing's always, but we're really very predictable. And in these cases, they're just socket grafts. There's no membranes being used. And I tell the patient if it's really a bad socket, I says, you may need a ridge augmentation here. And then they're prepared and they have no problem with it. Okay. Apical fenestrations, you're going to run into those a lot. Loss of the crown. You don't even know that there's a fenestration up there unless you're doing a CT scan. I don't do a lot of those, but you would know that there's one there if you did one. And so I took the tooth out, and now I've got a fenestration up here, and I've got a curette in here, sort of pulling the tissue up in the area of the fenestration. But I'm doing one other thing. When you have a fenestration at the apex of a tooth, what you want to do is remove all the granulation tissue, but then take an instrument like an angled curette and try to dissect the surrounding tissue off the periphery of the fenestration. So now you're going to have a little exposed bone around your fenestration, because what you're going to do next is you're going to pack in your graft material, and you want the graft material to go outside of the fenestration. Then what you do, you can feel it. Obviously, it's like a mushroom over the fenestration. And then what you do is you take your finger and you smooth it out. So now instead of a mushroom, you got a layer, and that layer actually covers the surrounding bone because you've dissected it a little bit, and you'll get a beautiful result. However, here's the thing. With the material, it doesn't make any difference if you graft it and it's got a piece of ceramic or titanium in the middle of it. It's going to heal identically the same. So the technique is actually the same. It's just you're doing the grafting because you've got a problem, and then, you're putting in an implant. It doesn't really make any difference if the implant's there or not. Treat it all the same. Temporization, and you can see that underneath the mucosa, you can see our graft material in the area of the fenestration. This is the day of surgery. This is the day of impression. You can see that we've maintained a gingival margin. Okay. Extensive furcation. Now, is there anybody need a break or anything like that? I think I'm pretty close to being proper time. Anybody tell me how much time I got left? How much? No problem. We'll be on time. Okay. Extensive infection. Okay, I mentioned earlier, you talk to your oral surgeon, I can't put a graft there because it's so infected, we have to take it out. Let the bone be exposed. Let the bone be exposed to every virus and bacteria that's known to man, and hopefully the patient doesn't catch something and they don't get a dry socket. But you got to get rid of the infection. Well, I graft everything. Here's a case where we have just extensive infection all the way down to the inferior alveolar nerve. And when I took the tooth out, it bled so profusely, there's no way I'm going to be able to graft it. So I just packed gauze inside of it. It really took me longer than you would think to realize that, you just don't want to have a patient bite down on the gauze, because that's what we're all trained in school, right? Oh, bite down on the gauze. Well, the thing's pumping crazy blood. Well, as this type, I thought, why don't I put it in the socket? And so it works beautifully. Just pack the gauze in the socket. 5 minutes later, the bleeding stopped. Fill it up with socket graft putty until it just flows out. You want to start at the apex. You get your tip down as best as possible, and if you've used our products, the tips are short. We've got a new tip being developed, should be on the market in a month or two, that actually will reach down to the apex of the extraction socket. And so here we have our socket seal, bonded, sutured. This is the day of extraction and grafting. Here's our socket seal. Here's our graft material. Whenever I have all walls present, doesn't really matter how big the lesion, I just use the putty because the walls are going to support the graft. This is day of implant placement. I think it was 3 to 4 months later. This is the ridge. You can't see anything there, but this is bone. That's the ridge. Okay. Now, you guys know a lot more about bone pathology than I do. I honestly don't know anything about bone pathology. My whole career in this field has been focused on finding out how can I grow bone. And I don't really know much about bone pathology. So I don't really know what's going on in the bone in a pathologic situation. So that allows me to be ignorant, okay? So when I see poor mineralization, I don't know anything about it. And so, but what you can see is, you can look at this and see that it's poorly mineralized. But whenever you see a mineralized crest and a significant decrease in mineralization below, you know that you got a problem, and you know that you're not going to have much mineralization there. I tried to do a core sample, but the treffin, as soon as it broke through the crest, just fell into this, and there was no resistance. Oops. Here's the crest, and so what do I want to do? This is not an ideal place to put an implant. It increases the potential of failure to integrate. And so what we want to do is we want better bone quality. So what I do is I make my osteotomy, I fill it with socket graft putty, and I drive my implant in, and you can see the putty is out here. Just by the crest. Yeah. You have to be pretty delicate. You can't wobble, you know. I understand what you're saying. Crest? Are you talking about a torque wrench? What's that? I've been doing implants since 1983. They never taught us what a torque wrench is. I hate to say that, and I admit I got a new kit. It's got a torque wrench in it. Yeah. So I've got a torque wrench. My torque wrench is my fingers. I'm that bad. Okay. And so no, I can't really tell you what the torque is, but obviously in situations like this, you want to be gentle and you don't want to over torque it. See, to me, here's the thing. I don't care if it spins. I don't care if it wobbles. I know how to treat it so it's going to integrate no matter what the torque is. Now, with other types of materials, you have to have torque for stability. And in fact, and let me explain this, did you know in allografts and biowas, there has never been a study published that has shown integration to the implant surface? It's all we think. Now, I'm not saying you don't get integration. I personally don't see how it can happen biologically. So if you torque that thing down and it's nice and solid, well, it might be nice and solid not because of integration, but it might be solid just because it's a screw and wood. And so I'm going to get better with using torque wrenches because it's a good way to communicate. I could answer your question if I use it every once in a while. Next time I talk, maybe I can answer your question. Okay? So yeah, you can't put much torque, and you can't, and you just, there's nothing here to stop the implant from driving down, so you just screw it down until you get here and you stop. And this is what it looks like a couple months later when we're going to put our healing abutment on. And you can see that the bone that's now been regenerated is equally dense as the surrounding bone. So when you're in the situation where you have poor mineralization and you feel you're not going to be able to torque your implant down, or you simply know it's poor mineralization, and so you got a really lousy vitality and lousy bone, fill it up with a little graft material and change the vitality during the integration process. Okay. Before, after. Significant difference in mineralization. Okay, here's another tip. If you ever take a radiograph of a mandible that has fairly normal height, and you see this, you know there's no bone here. This is reactive. This thick cortical bone doesn't happen in normal mandibles. You'll have a thin crest in a normal mandible, but if it's ever thick like this, you know that you have virtually no mineralization in the cancellous bone. Because what's happening is the cortical bone is increasing in thickness because it has no support internally. It's a reactive process. And so I knew that I didn't have any bone mineralization here. One problem is that it all depends on the angulation of your radiograph. I take a different angle, and that's not going to show up. So oftentimes the first radiograph will look like that's fine, but you got to get the angle of the radiograph correct to actually see this dense cortical bone. So we don't have any mineralization. It's just falling in. And so what I did is I injected my graft material, drove the implant in, and I am very confident this is going to integrate and just be fine because we've changed the vitality of the tissue. And we're going to increase the density of the bone during the integration process. Okay, exposed threads, common problem. Common problem. I just use socket graft putty mixed with our osteoconduct granules, and we do a pretty good job of regenerating. Yeah. Yeah. Mm-mm. It's a fresh implant surface, so I don't need to. No, this is the day of implant placement. It's not a chronic thing, no. And so, yeah, I would perforate a little bit here, but you ask a question, it forces me to make the question a lot more complicated than it should be, the answer anyway. People talk about perforating the bone to get bleeding. That's what you need to do when you use bone grafts that heal via inflammation. Allografts, BioOs, they heal through an inflammatory process, and that inflammatory process requires blood flow. Our type of materials that heal through a normal process of healing, we do perforate the cortical plate, but not for blood, for the access of regenerative cells. So we perforate it so the regenerative cells that are inside the cancellous bone can get into our graft material and grow through our graft material. So it's a total difference. Same thing, but it's a different method of getting the bone to grow. So yeah, there's this, and here's I just covering it with graft material, and we've got some nice regeneration. Now, you asked about membranes earlier. I don't use any membranes here because we don't make them, but there are instances where membranes are very useful, and so my job usually is to see how far I can push my products, to see how far I can go to solve a problem as simply and as cheaply as I can. But then I also get to the point where I say, okay, I need something different here. So actually, we're going to talk about membranes in the ridge augmentation section a little more. But there's the bone that we regenerated, socket graft putty, and granules. Okay, sinus augmentation. And we're running close to time, and we'll zip through this. For sinus augmentation, we want to be as atraumatic as possible, reasonable in cost. So what I do is, here's the bottom of the sinus is right about here. Oh, and my wife insisted that I tell you this technique's called the Steiner sinus lift. Okay? Thank you. So the sinus is right here. I'm going to use a number 8 or number 10 round burr. And I'm just going to go in about the millimeter or so that's necessary to get to the membrane. And this is just 3 millimeters. Now, if you take a ball to try to push this away, the ball is so tiny that it just punctures it. So we had to make paddles, and this is like a 1 millimeter paddle, so it's flat, and you just start here with the edge of your paddle, you slide it over the bone until you feel that you're on the membrane, and then you just slip it underneath the bone between the membrane, and you just go around here, and you dissect about 3 millimeters. Then you get in with your ball, and what you do is you go with your ball and you just go to the floor of the sinus and you sweep back and forth. As long as you keep your instrument on bone, you will never tear the membrane. And so you just sweep back and forth until you get to the medial wall of the sinus. And actually we have this ball, but then we have one that's a little longer in case it's a pretty wide sinus. But same thing. And then we inject. And so the reason you have to go dissect the floor of the sinus is because when you inject your material, that void will fill up. And when it fills up, the pressure will push against the hardest part, right? And it'll push all the softer parts away. So the hardest part is the floor of the sinus. So that's where the pressure builds up, but it pushes in a coronal direction. So you're pushing your membrane up because you dissected the membrane off the floor. If that makes any sense. Does it make sense? Okay, thank you. You asked, how do you know how much to put in? Well, here's a pretty large sinus. Put my little perforation here. I'm going to go in and I'm going to do my first injection. This is maybe 1 to 2 cc's. And what you see is a nice dome. You know right here that the membrane's intact. It's never going to tear no matter how much you pump in. And so how much rise do you want to your membrane? You just keep putting the material in. This might be 3 syringes, which is 6 cc's. And unless you have a CT scan, you're never going to know because some sinuses are very narrow, some sinuses are very broad, so your volume is unpredictable from a regular periapical. Only way you would know how much volume you're going to need is if you took a CT scan. And so this is implants the day of placement. As I say, we always put the implants in the day of placement because we know we're going to get integration here. And here's 3 months later. This is a different density, but it's very good bone that's integrated. Another case, I'm going to put my little perforation here, but I perforate it a little bit. I ignore it completely, and it's never been a problem. I just go in with my balls and my paddles, and I dissect off the floor, and I inject it. And that little perforation doesn't seem to tear like you think it might. And you can see that the graft material is filling the sinus and the membranes up here somewhere. This is the day of surgery. Let me see, the day of surgery. This is the day of surgery, the implant placement with the graft in place. This is 3 months later that we're putting on the healing abutment, and this is 2 years later. The goal of my surgery and the goal of everything that we do, we want to make the patient whole again. I don't want any compromise. I just want to make them whole again with their own tissue. It's called tissue engineering, to regenerate their tissue, and that's what I want for a patient. This patient, you could never tell, had a sinus augmentation. Okay? I ignore it completely, and I proceed with my dissection of the membrane on the floor of the sinus and my injection of the graft, and it elevates, and I've never seen the membrane tear. Even with it's not like a big tear, though, that's different. But just a hole like that doesn't seem to affect. Okay, here's a little more challenging sinus. Has a nice little mucus retention cyst to add a little complication and interest. What we're going to do is we're going to put in 3 implants. This implant, as you can see, is going into completely normal bone, patient's own bone. This is probably 80% graft material. You can see that the graft material is out here. This implant's going to be in 90% graft material, because you can see I'm putting it in a place like this. Well, what happened with this case is that this sinus, when I laid the flap, I'm not used to seeing this, the buccal wall was dark. Everybody knows that when you're getting close to the membrane, it gets dark because the sinus is dark. It goes from white to dark. And so I wasn't thinking very well, and I just had my high-speed burrs, which I used to make their initial osteotomy, and I touched the buccal of that, the lateral wall of the sinus, and it just tears the membrane. The problem was, it was one of those membranes are like working with wet tissue paper. As soon as I touch it, it shreds and it's gone. So what we did is I just got into my osteotomy, and I just scraped all the membrane out all around here, buccal, lingual, everywhere. There's no membrane here. And I just filled it up with graft material. However, if you're going to do that and you don't have the membrane to retain the graft material, you need to make sure that you sort of have your graft material pointed down so it flows down and then up, if you see what I mean. You wouldn't want to just squirt it up because there's nothing to stop it. Okay, so, and this is what we have here. Day of surgery, 3 months later. We're putting on the healing abutments, and you can see here's the regenerated sinus membrane. The graft material, sinuses are very dry. The sinus graft material will set in about a half an hour. So when you do a sinus graft and you prepare your osteotomies after the graft is in, you need to go the full depth of the implant, because you need to be able to screw your implant up into the sinus, and if it's set, you're just going to screw, the graft is going to raise with your implant. A mistake, I've done it. And so that's why I can tell you about it. So basically this is healing abutment day, this is day of surgery, and this is 15 months post-op. And we're just checking the health of the implants. And what I want to show to you is we're talking about osteogenesis. And we're talking about stimulating bone formation. And remember, we said that this implant was completely in normal bone. But you can see there's a difference between this bone that was there before and this bone. There's a significant increase in density in the bone that's been around the graft. So what happens is the osteoblasts get into the graft material, they're stimulated, they form bone, but then they spread out in the surrounding tissue and increase the vitality and the mineralization of the surrounding tissue. And that's why you can see this mineralization front as it's proceeding in this direction. Okay. Can't do an immediate implant because of the proximity of this tooth. We grafted. Well, I don't have quite as much length as I want. There's the floor of the sinus, so I'm just trying to get a little pin prick through. I'm going to inject my graft material here, and this is where the bone, the floor of the sinus is 3 months later. Simple sinus bump. Okay, I got to move because I don't want to be late. If you take this tooth out here and you just wait, this will go away, and it'll go away very quickly. Because the only reason that bone is there is because that root's there. So you want to try to preserve this bone for the implant that the patient wants. So in that case, what you do is you use granules with your graft material. Because when you think of it, if the granules will not resorb for 3 to 6 months, then that volume is going to stay there at least for that period of time, because the granules aren't going away and they're not going to lose volume. So you pack it with granules and putty, and you're able to maintain that structure for your implant, hopefully avoiding a sinus augmentation for your patient. Okay, we're down at the end. This is a product we developed. It's called cortical plates, sort of to mimic bone's cortical plates. I'm not quite used to this changer. I don't know why. And so you can see the void that we want to graft. Buccal lingual cortical plates, the defects. Perforation of the cortical wall. Here's our cortical plates filled with our graft material. Graft in place. This is 2 months post-op, and we're starting to get mineralization up to here. Pre-op, post-op. Pretty good. You're leading into my next statement. We don't. And that's the problem with this technique. In that area, the tongue is going to push it out of the way. We're trying to put Essex retainers over to prevent the tongue from pushing it. But this technique, we've been using it for a few years, and we've been learning about its shortcomings, but we've also been learning about what it can do for us. And so these plates are going by the wayside very shortly. And what's going to happen is that you're going to send us a 3D scan of your patient, and we're going to print this model. And then we're going to print this bone graft. And this bone graft is going to have a lattice structure in it. And then we're going to fill it with our bone graft material. And you're going to tell us where you want your implants, and we're going to drill 2 screw holes, and that's what's going to hold it down. So the process is you send us a CT scan, you get a bone graft in, you perforate the cortical plate, you screw it down, and hopefully 3 to 4 months later, you take the screws out and screw your implants in. So that's where we're going with that. The last little feature is membranes. Membranes have a place there for those moderate problems, but I don't like resorbable, and non-resorbable is what I recommend to everybody that's using membranes that need to use a membrane. Use a non-resorbable membrane because it doesn't cause inflammation. But we have in the works right now a resorbable membrane that does not cause inflammation. And I don't know how long it's going to take for that process to get going to the point where we get it on the market, but that's where we're at. I thank you very much for your time.